webinar on viral disease. And now we have from Dr. Shyam Kottilil. Dr. Shyam Kottilil, MD, PhD, is the Director Clinical Care and Research at the Institute of Human Virology. He is also Professor of Medicine and the Chief of the Division of Infectious Disease at University of Maryland, School of Medicine, Baltimore. Dr. Kottilil continues to work as a Scientific Director of the NIH District of Columbia Program for AIDS Progress. He received his medical degree from Government Medical College, Thrissur, India, PhD in Immunology of HIV infection from Memorial University of Newfoundland, Canada, completed a residency in internal medicine from Brown University, Rhode Island, and a fellowship in infectious diseases from the National Institute of Health under Dr. Anthony S. Fauci. His specific interests include pathogenesis of chronic viral infections and translational research to eradicate chronic persistent viral infections by targeting the virus and the host. He has conducted several pivotal investigator-initiated studies in hepatitis C, and he has authored over 250 peer-reviewed publications. Dr. Kottilil served as one of the founding members of the U.S. National Hepatitis C Treatment Guidance Panel. He is a member of the American Society of Clinical Investigation and recipient of Hinda and Richard Rosenthal Award from the American College of Physicians in 2019. Dr. Kottilil is elected as a Fellow of Infectious Disease Society of America, American Society of the Liver Disease, Royal College of Physicians, London, and Mastership of the American College of Physicians. So it's indeed a great pleasure for us to have the talk from Dr. Shyam Kottilil, and even with his very busy schedule, he was so kind enough to accept our invitation, and we express our sincere thanks to you, sir, for your kind support, and I request sir to continue the session.
We all know that SARS-CoV-2, a beta coronavirus, is responsible for COVID-19. And this is the structure, and the structure of SARS-CoV-2 is characteristic of these spikes that stick outside, and they are they bind to the receptor AC, angiotensin converting enzyme 2, that is present on respiratory epithelium and get into the cell. And that's how they actually get into the cell. This particular SARS-CoV-2 is very similar to the original SARS-CoV coronavirus that appeared in the early 2000 time. And there are generally two types of coronaviruses, alpha and beta. Alpha has a primary host in birds, and beta and primary host in bats. And this is a very interesting fact that bats and birds are not usually killed by the disease. Bats particularly carry SARS-CoV-2, and then it can transmit to other bats as well. And it is not, so far, this particular SARS-CoV-2 is not jumped species, but it's been quietly described in bats by very few people who actually worked on bat and coronaviruses in bats. So this is the structure, three-dimensional structure of SARS-CoV here, and this is the SARS-CoV-2. They're very, very similar. And if you just look at it, if you try to overlap it, it's pretty much identical, except for very few reagents. And then still, this is such an identical virus that came up. Why we did not develop a vaccine or did not study therapeutics for this particular virus is one of the major mistakes that done over the last 18 years. And we were completely underprepared. Even the studies on common coronavirus that happen, seasonal virus, is not well studied, not funded by anyone. That created a lot of problems, a lot of gaps in preparing us for this particular pandemic. So we had all the information available. We just did not utilize for the benefit of this particular dealing with SARS-CoV-2. So once you get infection, from a virology perspective, you get infected, you get symptoms, you start symptoms, and that in the first 3 days is when you really have the peak viral load infectivity that's seen in the respiratory epithelium, and by sneezing and coughing, it can spread out as droplets. So most of these people, secondary infections occur within the first 5 days of someone's contact with the people. But they can still become positive at day 10, and after day 10, most people are not positive for the SARS. Most people are not, but there's some people continue to shed, And that's really are people who have deficits in immune system, such as immunocompromised patients, cancer patients, etc. And there are case reports of people shedding beyond a month time. And of the value, the clinical value of that shedding is not completely understood. For all practical purpose, we think that the first 5 days are really critical, and beyond that, it's really not significant unless you have a patient who is immunocompromised. So that's the key, and that's the whole logic of quarantine of people, as well as people being self-isolation when you have symptoms, is based on this understanding of the shedding of the virions from patients. So what kind of tests can we use? Usually, most of you have been tested at least once with SARS-CoV-2. This is a deep nasopharyngeal swab that people take it in, and that's what you usually used as the most high yield for SARS-CoV-2 when you're infected. And in the time after start of the infection, the first 5 to 6 days, in the first 5 days, you're going to shed virus nucleic acid test, PCR-based tests are the gold standard. You also can test for antigen at this time that can also detect parts of the virus, and that can also have the same degree, even though PCR will have the maximum degree of sensitivity. So you can develop antibodies over time, even though we don't use antibodies as a diagnostic tool for SARS-CoV-2. They've been used for a variety of different serological seroprevalence studies. And you can see that people looking at how many people have been infected with the particular virus and try to understand the burden of the disease, and not so much of as a diagnostic tool. One point to mention, like all infectious disease, there is a point with the antigen-antibody interaction that you could have negative antigen and negative antibody, so that may not be really diagnostically a challenge with this patient population. It's another very interesting aspect of SARS-CoV-2 is that it has a spectrum of disease. That means there are one end of the spectrum, people have no symptoms, and the other end of the people are admitted in the ICU, and they have a high degree of mortality. And this creates a lot of confusion in the public sector. The people think, hey, I got it, I have no problem, and then somebody else, could have a very serious outcome. And a lot of the effort and research is trying to understand who are those people at the highest risk of developing serious disease. And once you identify those people, then you can manage them and prevent mortality associated with this. So if you look at these things, there are about 30% of the people have no symptoms, and they very quickly recover and they become immune. And those people don't die. Then there are people with mild to moderate symptoms like cough and sneezing, fever, myalgias, and those people are majority of the people. More than half of the people are there, and they will have symptoms a little bit more prolonged for 5-10 days, and then they recover, and the very little of the mortality associated with that group as well. When you started developing pneumonia, you started having hypoxemia, and that put you in a category of severe symptoms. When you have severe symptoms, then small number of people have severe symptoms, but those people require hospitalization, and those people also have a prolonged hospitalization and at a high risk of mortality. And then you have some small fraction of the people develop as something called as ARDS. That means you get respiratory failure, you can have multi-organ failure, all associated with the cytokine response. And those people can become in the ventilator, in the ICU setting, at a very high degree of mortality. So this is something to keep in mind. And the whole idea for us is that if everybody is asymptomatic, we don't have to worry about SARS-CoV-2. But the reason of all the aspects of prevention and treatment of SARS-CoV-2 is because there's some portion of these people can actually have very serious disease and die. So the clinical presentation is also quite broad, and no other respiratory disease have this kind of broad presentation. And you have the typical presentation like fever, cough, exhaustion, etc. But there are some really unique features like loss of smell and taste. That's pretty unique because we believe that it's because of involvement in the central nervous system and the olfactory nerve that leads to the smell dysfunction associated with SARS-CoV-2. Then you can also have GI symptoms, nausea, diarrhea, etc. Also seen in many of these people. When you have serious complications, severe disease, you get respiratory failure, multi-organ disease, kidney failure, heart failure, etc. A key element is a thrombotic phenomenon. Small clots form, and you see that in the early times it's described like this. These are all these microemboli that's called covetose. This is something that's quite recognized in people who have thromboembolic phenomenon this time. If you hear that's a chest X-ray, This tells you the pneumonia. The chest X-ray should black. The chest CT scan should look black, and anything white here is fluid, and that is in this particular case is pneumonia, and we call it classically described as ground glass opacities of the grapes. You can also have immune complex disease that you've seen here, kidney failure, kidney associated disease, and that is also and is part of the spectrum. Not everybody will get every symptom, but some of these symptoms will be present on everyone. So how do you get sick? There are two processes. One is viral replication, and the number two is uncontrolled immune response. These are the two reasons why people get sick. And so you have SARS-CoV-2 that get in, and it actually gets into the cells, and being an RNA virus, it triggers the interferon pathway. It also triggers the NF-kappa B pathway. Ultimately, that leads to a wide range of cytokines being released, and that leads to what classically described as cytokine storm. And this cytokine storm and all the cytokines have effects on a variety of different organs. It can give pneumonia, it can involve GI tract, it affects the brain, where you can have olfactory and the taste defects as well. It can affect the heart, myocarditis, liver enzyme abnormalities, kidney failure, microemboli, thrombosis, and conjunctivitis. All these are being seen as part of the cytokine storm. So most of the severe symptoms that you see in severe and critical COVID patients are because of your own immune response that's not controlled. And that's why the treatment has to be tuned that way. So here is another way to look at it. You can say an early stage disease, and you have a pneumonia stage and an inflammation stage. So all this time, most of the symptoms are mild. Most of the pathogenesis is driven by viral replication. While here it's viral replication and host immune response leading to pneumonia and shortness of breath. While when you become really septic shock, most of it is primarily driven not by viral response, but the host inflammatory response to the virus, which is abnormal in a small subset of people. So one of the good news about SARS-CoV-2 is not the worst coronavirus in terms of mortality. Most people have mild to moderate symptoms. About 14% have severe symptoms. 6% people are critical. This data is from early data from Wuhan, which is validated in New York City, as well as in my state, Maryland. It's pretty much similar mortality rate. But if you look at here, mortality by age, which is one singular factor that is associated with mortality, is older you are, more high risk of mortality. You see it after 40 to 50 years, the mortality goes up with SARS-CoV-2. And here you can see that when you compare to original SARS virus that happened in 2000, or the MERS virus, the Middle Eastern respiratory virus that is predominant in the Middle Eastern or the Gulf countries, the mortality is much higher compared to SARS-CoV-2 or COVID-19. So here is another way of looking at it. Is the crude case fatality rate is about 1 to 2% right now with SARS-CoV-2, but that is much better when you compare to SARS virus. It's close to 10%, and about MERS is still about 34%. So it's pretty high mortality disease. Fortunately, they actually self-contain or become endemic in certain regions, not creating pandemic. So this is the life cycle of SARS-CoV-2. SARS-CoV-2 is a beta coronavirus that binds to ACE2 and it uses other receptors like TMPRSS2, and then rolls over and gets into the respiratory epithelial cells. It uncodes and brings its own enzymes like proteases, chops down, creates this long template for RNA that undergoes RNA replication with an RNA-dependent RNA polymerase. And this particular RNA is then transcribed, different proteins are synthesized, and in the ER and the Golgi apparatus, they're packaged and secreted into the blood circulation. Along with that track, it can also induce all these cytokine responses, and that leads to activation of cytokines, innate and responses, and also secrete all these inflammatory cytokines that can be right. So this is good to understand if you want to target the virus. These are the ways to target. You can prevent binding, you can prevent replication, and you can prevent also release of the virus. Those are potentially good targets for against SARS-CoV-2, and has been worked on for the last year and a half. Deciding how to treat COVID-19 depends on understanding the pathology of the disease. So pathology of the disease in the early phases is mainly driven by viral replication. It means that's the main, because your symptoms are in the respiratory tract, the virus grows there and it gives you the symptoms. And so that's most of the aim of treating those patients is antiviral treatment. They're targeted towards the virus, preventing the virus from binding to the receptor, or blocking viral replication are really appropriate strategies in that stage. But when you develop severe disease, the viral replication is not there, or is not the most common pathogenesis, mostly inflammation response. Inflammation response is seen as in markers of inflammation go up in the bloodstream that leads to associate with severe and critical illness seen in patients. Hence, your therapeutic options are mainly anti-inflammatory options. That's what is required, becomes the mainstay of the treatment in patients. So this is something to understand, because we have to understand the pathogenesis and immunology before we decide to treat these patients. So there are guidelines. From the beginning, in the early 2000, we had no clue of how to treat COVID-19, and we were treating with them so many different agents. So there are guidelines, and expert guidelines have established to give recommendations on a day-by-day basis, because these things change every day, and it's really useful for people to be updated. So you can go to these websites and find out what exactly is new here, and they will tell you about all the recommendations of all the agents that you may have. Something that we don't recommend versus something we actually do recommend as well. There is also a separate guidelines from the NIH. It's also quite similar. They're very similar in terms of the recommendations. So either one of them will be very, very useful for people to take a look at and see what the cost is. So now, what are the therapeutic options to these? Before we had any therapeutic options, first thing we used is to use convalescent plasma. So what is convalescent plasma? You know that when they take blood and you centrifuge the blood, it's separated into three things. One is this plasma, the red cells, and the buffy coat, or the leukocytes and platelets. These plasma usually have most of the antibodies. So that means if you take this plasma, take the blood from someone who has recovered from COVID-19, you will assume that this plasma is enriched with the antibodies against SARS-CoV-2. We don't know that, we don't have time to test it, but if you take that plasma and then give it to another sick patient, you keep transferring that antibodies to that patient and helps that patient to recover. So this is done, and you can do that. All you need is people donate plasma after they recover from the disease, and everybody in the world have done this. Anybody with a blood bank can actually do it. It's not that complicated. And those studies were done to try to understand, see whether plasma from someone who's recovered from COVID can protect you from severe disease and mortality. And the studies have not shown any benefit for these things, because one factor is that we assume that there are a lot of antibodies in the plasma. Well, we didn't check for it because we didn't have time, because these people were really, really sick. So when you look at whether the people got the placebo or the sugar pill, or in this case, saline solution, there was no difference in death rate, mortality in about 30 days. That's something that most people look at. There is no difference in the two groups. But after the fact, when we go back and look at it, when you look at the titers against SARS-CoV-2, you see that the people who got very high titer plasma, there was a mortality benefit. So the mortality was only 22% compared to low titer people got 29.6. So if now the recommendation is that you have to check the titer, and you have to make sure the titer is there. It's 250 international units. If that titer is there, then it's advisable to give it to people who are really sick early in the disease. That means you're in the hospital, but not intubated, not in a ventilator. Those type of patients will benefit from getting convalescent plasma. Another group of people will benefit are the people who have no immunity, particularly those people who have cancer and other immune suppressive treatment. Those people also will not bound their own antibodies, so they would benefit from a high titer convalescent plasma. So then we have monoclonal antibodies, and you know that the monoclonal antibodies are also available in India. The monoclonal antibodies manufacturing is very quick now. You can actually use these monoclonal antibodies to bind to the spike protein, and they bind to the receptor binding domain of the spike protein. So the spike protein will no longer bind to ACE2, and they cannot get into the cell. So they run out of targets, and that's what ideal. So this has been demonstrated. Most of these monoclonal antibodies are against the spike protein. And here you can see, if you look at MERS and SARS-CoV-2, this looking specific. You look at the SARS protein with a GFP drive, it's the green dye. That's all these are SARS protein, and since the green in the first line, and this is the monoclonal antibody again. And if you just overlay it, you can see that the monoclonal use all these yellow between red and green. That will tell you that the monoclonal antibody is actually binding there, so that they co-localize to where the SARS-CoV-2 is there, where the spike protein is there. And it doesn't co-localize with MERS, which is very specific to SARS-CoV-2. And again, if you look at the pseudotype virus, that means the virus can replicate at least 1 or 2 rounds. And if you use that round, these monoclonal antibodies can then suppress replication because they can block them from binding to ACE2, and they will not really replicate. And that's been shown with most monoclonal antibodies that they can block the development, the proliferation of the SARS-CoV-2. So again, another way to look at it is that you have the human cell and you have to make SARS-CoV-2 is binding into the cell. This is spike protein where it comes in, and the monoclonal antibodies will come in here and then bind. And sometimes we use combination of 2 monoclonal antibodies and they bind to 2 different parts of spike protein. And that's because if you have a mutation, if you have a new type of SARS-CoV-2 coming, if it escapes one monoclonal antibody, it cannot escape both. So 2 monoclonal antibodies is generally better than 1 monoclonal antibody. So that's something that people have always used. So there are 3 combinations available in the United States. I believe at least one is on one of these combinations available in India. All of these monoclonal antibodies are against the receptor binding domain of spike protein. If they're used in combination, that means they use 2 different epitopes. They bind to different. So but they work together. Most of them are given as an intravenous infusion. That means you had to go to a hospital or a clinic to get it, except for the middle one, the one in the green one. That particular can be given as subcutaneous infection. That means you don't have to, you can give a small injection like you go to get a vaccine, and that should be enough. And subcutaneous injection can be given in a doctor's office. You don't have to be in the hospital. This is the combination that's available in India, and the other 2 combinations available in the United States. All of them will do the same thing. They will actually prevent SARS-CoV-2 from getting into the cell and then making you feel better. They have to be given very quickly, though, within the first few days, I think. So who should get the monoclonal antibody treatment? People should have a very early in the disease. That means mild to moderate disease. If you're really sick, monoclonal antibodies would not work. But I told you that that's when the host immunity steps in, and it's not the viral replication. So targeting the viral replication doesn't seem to work at that time. So mild to moderate disease is what you have to do it. Have to be an adult, and you have to have early disease after 10 days. You probably don't need to treat these people. And then there should be in a category that they should be at high risk of progressing to COVID-19 hospitalization. And that's the key. So who are those people? That's an important question that we need to find out. And according to the CDC in the United States, they have looked at study the data. These are the type of people. The most important thing is age. Anybody over 65 years old worldwide at the highest risk of mortality. So those are the people should be protected. People with overweight, pregnancy, people with kidney disease, diabetes, immunosuppressive disease, cardiovascular disease, etc. All these patients are at highest risk of developing progressive severe COVID-19 and dying. So if you have any of these conditions and you know that you're symptomatic early within the 10 days of symptoms, then you should be eligible to get the monoclonal antibody. So there are other conditions, something to think about. Over time, we look at people with Down syndrome, people who are smokers or past smokers, or people who have a disease like thalassemias, people with substance use disorder, some minority groups, people with disabilities. All these people are at high risk, and if you have any of those people, you can give monoclonal antibodies, and that will be helpful for them. The key element for that is the cost of this monoclonal antibody treatment, and that's also something to consider. But it is definitely not cheap. So how does it do it? So if you have to study this by using a combination. Some group of people will get the monoclonal antibody, and some people get saline or nothing, or a placebo. And then you look for this group of people, how many of these people got hospitalized after you received this medication. And generally about 7% of the people who got the placebo get hospitalized, and that's shown here. And if you receive the monoclonal antibody, that's about 2%. So it's not that it eliminates the risk of hospitalization, it reduces it significantly, about 70%. And if you look at that, how does it do it is by bringing the viral load down. So you have the placebo here, that's a viral load that's coming down. But if you give the monoclonal antibody, the viral load comes down much faster. And people also have better symptom relief as when you get monoclonal antibody. And so it's really a good thing to do, because especially people at highest risk, older people, they should be get this medication as soon as possible. And same data with this combination, casirivimab, imdivimab, is made by a company called Regeneron, and they also have shown similar effect, about 70% of protection if you use this particular combination of monoclonal antibody, and they also reduce the people viral load, and people have better symptom relief when you receive monoclonal antibody compared to placebo. So you get symptom relief and you can actually get a better response. This is a unique monoclonal antibody called sotrovimab. Sotrovimab binds to a part of the receptor binding domain of spike protein that is very conserved. It doesn't mutate a lot. So you can use it as a single agent. And in the other cases, you had to use two monoclonal antibodies because you're seeing so many different variants now. So if you give this monoclonal antibody again, you have about 85% reduction in hospitalization for this group. So that's all these monoclonal antibodies work similarly. Any of them will do, and whatever is available would be beneficial if you have someone who is older and has a comorbid disease that puts them at highest risk. The things have changed over time, right? Now we have what you call as the Delta variants and the Delta variants that's up. So if you just look at the incidence of cases, what infections were caused by which type of variant, you can see that the light blue, or the B117, otherwise called as alpha variant, was the one predominant in about June of this year. Most of the infections is caused by that. The orange one is a Delta variant, and that's very, very minimal, less than 5%. Over time, you can see in like about next to 2 months, the orange has taken over. For all the percentage of all the cases, almost 99% cases are due to Delta variant now in the United States. And this is probably true globally. Most places they have taken over because they have an advantage of establishing chronic infection. Then the question comes up, all these monoclonal antibodies, do they work against Delta variant? And you can test that in the test tube, right? You can take these variants and then test them in the presence of monoclonal antibody for neutralization effect. Just do a standard neutralization assay. You can see that the ability of neutralizing of this individual monoclonal antibodies are lost. You follow the orange line. It's lost for this monoclonal antibody. It has no neutralizing ability here, while the other ones maintain neutralization activity. So that's one of the reasons single monoclonal antibodies are no longer recommended. The current recommendation of the combination monoclonal antibodies do work against these particular variants. So you can also look at pseudotype virus. You can create these mutations in the laboratory and then look at neutralization ability against different combinations of monoclonal antibodies, and then compare them to ability to neutralize the wild type virus. And then you can say how many fold change that's neutralization effects are having seen. So you can see on the left side, if you just look at and the different strains, the alpha strain, the beta strain, the gamma strain, the delta strain, or epsilon strain, the different combinations, you can see that they maintain good effect against the delta strain. It doesn't have the same effect in other strains, the gamma and the beta, but we don't see that often. So that's really not a major epidemiological problem. Most of the infections we see delta, and all of these monoclonal antibodies work against delta so far. So that is a good news that you can still use any one of those monoclonal antibodies to prevent progressive disease. A key new information that come up, you can also use as post-exposure prophylaxis. Post-exposure prophylaxis means if you have really sick person, you have some disease that puts you at very high risk. You have cancer, you're like 85 years old, 90-year-old in a nursing home, and working in a hospital, and you suddenly got exposed from a healthcare provider or somebody in the same hospital setting, then you are a very high risk. Can you just take these monoclonal antibodies and prevent getting infected? And that's the question post-exposure. So you can actually prevent infection. So you don't have time to develop vaccination. Vaccination will take time. So this is something kind of a pre-made mix of protection that you can actually take it. And that's also true. You can, if you have a high risk of developing COVID-19, you're not fully vaccinated, and you have one of these conditions that put you very high risk. If you take these monoclonal antibodies, you will do fine. You will not get infected. And what's the data looks like? If you look at here, there is an 81% reduction in the development of COVID-19 if you receive monoclonal antibody. There is about 66% reduction in people getting any kind of COVID-19. So they not only it kind of aborts the infection, and even if you get infected, you get a milder version of it. So that is maybe it is something used in the United States. We use it in places like nursing homes where there are a lot of older people live, and when you can get these infections, they're one of the person can get it, or sometimes a helper can come in with an infection, and it rapidly spreads, and a lot of people can die very quickly. So this is something that's been used. So keep in mind is that post-exposure prophylaxis is not a substitute for vaccination. We still have to vaccinate people. This is only for those people who just don't have the time to get vaccine and be protected because they already got infected. Monoclonal antibodies are not. You cannot keep taking it as a pre-exposure prophylaxis. That's not. You have to give it as soon as possible for SARS-CoV-2. So now I'm going to switch gear to talk about some specific agents that can be used, and I'm going to talk about what the merits of using these agents are not there. So remdesivir is the only antiviral that we use today that's been approved to use in SARS-CoV-2. What do they act? They block RNA-dependent RNA polymerase. So that's what it does. So that it has an effect on blocking replication of SARS-CoV-2. So this was first developed against hepatitis C. Did not really show much activity against hepatitis C virus. But it has activity against other viruses in vitro. Has been studied against a variety of different infections such as Ebola and even Nipah. Technically, it should have activity against these things, but it did not show any clinical benefit against studies in Ebola. And this was a time when remdesivir had no particular role, and it was almost in the garbage can when SARS-CoV-2 came. So when SARS-CoV-2 came, remdesivir is the only antiviral that's already pre-made here. So it makes sense to use remdesivir. And if you look at remdesivir against the fact it does have an effect in blocking replication SARS-CoV-2 and MERS. And you can see here, this is a MERS human kidney system that has MERS virus with them. All the black spots in immunohistochemistry are the MERS virus. And if you treat them with remdesivir, the black spots will go away. So that means there is a reduction in the viral replication because it blocks the RNA-dependent RNA polymerase. So in the test tube, it makes sense. And so you have to really study it in clinical studies. So the first study was done in the early part of 2020, where they took about 1,000 patients and they gave them remdesivir or a sugar pill and wanted to see whether there is any effect. And before this is the time when what they looked for is that, do you get better? What time do you get better? So people got the sugar pill got better in 15 days as an average. But if you got remdesivir, you got better about 4 days before. So that means there is a slight benefit from them. You can get out of the hospital. That's the time when a lot of people were in the hospital and we wanted to get them out of the hospital. So remdesivir made sense at this time. Mortality benefit, would they help you from not dying? It's not 100% clear. The study was not powered to do that because it was stopped earlier. We really did not understand whether there is a benefit. There is a trend towards mortality benefit, but did not really translate into a benefit at all. So this tells you who are the people who get benefit from remdesivir. And I told you, remdesivir is an antiviral agent. The more advanced, the more sicker you are not likely to get benefit. So if you look at, these are the overall benefit from remdesivir. This is the proportion of the people who recovered. So the higher this value is better. So the blue value above, blue should be a lot above the red line. Here you can see that the people who are not receiving oxygen, there is some benefit. The people who are on oxygen, there is some benefit. But as the people get sicker, they are on mechanical ventilation, they are on ECMO, and they're intubated. You don't really see much benefit from these patients. So the people who got benefit are the younger people and the people who are actually in the hospital on oxygen, but not in a ventilator. So that's the early group of people in the early stage of hospitalization showed some benefit because they have a recovery of the benefit. The confusion about remdesivir happened because WHO did a study called Solidarity Study. And that one, they looked at a lot of hospitals in 30 different countries. What they did not do is they did not compare one drug against sugar pill, which is ideally the best way to do the study. But what they did, they looked at divided group of people into different regimens. So some group of people got remdesivir, you call it cohort randomization. Some people got hydroxychloroquine, some people got interferon, etc. But what they looked for is a more relevant endpoint, not when you got better. When do you have a benefit in mortality, or how many people died in 28 days? That's more of a relevant endpoint. And the study results shown here, you don't have to talk much about it. Any of these drugs showed any benefit. None of these, the mortality benefit at all. So this creates some confusion about whether remdesivir is going to be used or not. But I think if you just look at the data second, there is a use for remdesivir much earlier in the disease, when you're much earlier. But once you get really sick and you're ventilated, the remdesivir does not have a lot of role. So the other agent we use is corticosteroids, and most of you know corticosteroids block the immune system, which may not be a good idea, right? When you already have an infection, blocking the immune system may not be ideal. So that's something that has been shown before. If you look at SARS and MERS, when people were treated with the corticosteroids, they actually had a higher mortality. They died earlier. Even for influenza, if we don't use corticosteroids because corticosteroids are associated with bacterial pneumonias and higher mortality. And that's because you have this early stage and this late stage, right? In the early stage, you had the virus is replicating and you want your immune system to come and control the virus. And as you have more inflammation response here, you don't want the inflammation, you want to suppress the inflammation response. So that's the key. In a patient, you have to be able to recognize which stage they are and then use corticosteroids. If you use it too early, it may not be a good idea. I want to go back and explain to you, because most of you study immunology of virology in the disease. You can see that in the timeline, we have a disease, virus will go up, and that will trigger innate immune responses. Innate immune responses will actually trigger innate immune cells that also lead to antiviral responses in adaptive responses, that T cells will come in and start secreting cytotoxic T cells, and neutrophils will come and start getting recovery of the patients. So these people actually will recover. But if you give steroids, if you block this effect, if the innate immune system is not able to trigger the adaptive immune response, then the whole hell uses out, right? So you develop uncontrolled inflammation, and then it will lead to severe inflammation, disease, and then you have the cytokine storm, etc. So this is the logic that you have to use it appropriately in a timely manner. Corticosteroids also have a lot of side effects. And if you look at the right side, it affects the eye, it affects the brain, it affects the immune system, liver, heart, GI tract, skin, bones, etc. So if you take a lot of steroids in the hospital, you may have recovered from COVID, but you still get diabetes and other problems. And that's something you need to be able to concern about. It also has a very non-specific effect on a variety of immune cells, monocytes, neutrophils, lymphocytes, T cells, vessel permeability, fibroblast activity, everything else. All of them may not be required. Some of them will become side effects. Some of them will become beneficial effects. It's a very blanket approach to treat the disease. However, that's all we had at this time, right? So a recovery study was done by University of Oxford. So they looked at patients hospitalized in the National Health Services in London, and they randomized them to, again, the similar cohort randomization. Some group of people got no treatment, some people got dexamethasone, some people got hydroxychloroquine, and they looked at people for who died in 1 month. And so try another way to find out which of these treatments helped them to recover. So if you look at the data, excuse me, overall, there is a benefit if you use dexamethasone. If you're on oxygen, that's early stage, not on a ventilator, you still had benefit. Even when you're on a ventilator, your mortality is very, very high, but addition of dexamethasone lowered the mortality rate. The group did not benefit are the group of people in the hospital, but not on oxygen. So these are the people who are waiting for some procedures or waiting for a confirmation test to be to go home. Those don't give dexamethasone to those people because they don't have the cytokine storm. So if you are able to oxygenate well, if you don't have bad pneumonias, do not give dexamethasone. If you give dexamethasone, that could be a really, really bad thing. The next agent, I'm only going to talk about 2 more agents, is an agent called baricitinib. Baricitinib is an interesting agent. It's already approved for treatment of arthritis, and it's a JAK inhibitor. The JAK inhibitor is Janus kinase inhibitor. Most of you know that Janus kinase 1 and 2, mostly in the signal transduction pathway of T cells. And you can see that if you block JAK1 and JAK2, it blocks most of the cytokines that are produced here. So you can hear in type 1 interferon response, it blocks interleukin response, interferon gamma response, IL-12, IL-23 response, and even the growth hormone and the thrombopoietin response. It has a very good selective inhibition of T cell response to inflammation. So it makes sense that baricitinib may be better than corticosteroids in using this thing. So the study that NIH did was combined remdesivir and baricitinib in patients who had COVID-19, severe COVID-19, and then one group received only remdesivir at sugar pill, and the other group received remdesivir and baricitinib. So what happened again, the primary outcome was time to recovery, not mortality. There was a very modest benefit of adding baricitinib. 7 days, people got better in 7 days instead of 8 days. And you could say that this is not a big deal, but most of these patients actually do get better. So who got better are the people who are actually had really, really sick, but not at ventilated. Those are the patients who were benefited from baricitinib. So baricitinib is also an option for some subgroup of people if you want to add in addition to remdesivir. So who receives remdesivir? Anybody who's hospitalized, you can receive baricitinib. And I don't think baricitinib is widely used outside the United States, but it's still proven if you're available that it can actually reduce, has an important impact in getting better much easier. The last agent is antibodies against interleukin-6. Interleukin-6 is a cytokine, most of you know, that is secreted as part of cytokine storm, not only for SARS-CoV-2, as part of a variety of other disease syndromes such as CAR-T. And you can block interleukin-6 can have an effect on cytokine storm, definitely in doing that. What is a study that leads us to do this? Early studies from Wuhan showed that if you look at people who survived from COVID-19 and compared people who succumbed to COVID-19, who died, and what difference was, they actually had an inflammation response, much higher D-dimer response and IL-6 response. If people did not have IL-6 response, they were fine. So the logic is that if you can suppress the IL-6, then can you make the non-survivors survivors? So there are a large number of studies were done in Italy and China and parts of the United States, initially with tocilizumab, but the final study that showed some benefit of tocilizumab is the same recovery study in the United Kingdom. Here we look at mortality benefit. If you receive tocilizumab, there was a mortality benefit in a subgroup of people who had a lot of inflammation response. And that's the group of people who had reduced mortality and they were discharged alive from the hospital. So tocilizumab is something that you can use in patients, with subgroup of patients who have a lot of inflammation markers. And so I think for someone who is sick in the hospital, there are only very few options available. You can give remdesivir for people who are hospitalized with severe COVID-19. The most benefit is seen in patients early in the hospitalization. I mean, they're on oxygen, but they're not on really bad ventilation. They're not really, really sick. When you get really, really sick, you really don't have that recommendation. Corticosteroids are useful for hospitalized patients, and do not give them if they are not sick. They're not. So most people who are hospitalized, you are on oxygen, will receive corticosteroids. The other two agents are only used in subset of people who may or may not have very, very high inflammation response, and it's not very widely used as well. So where are we at this time? This has been extremely confusing time for us. I think you all know, as students, you have to look at data, and now you have to find out exactly what data translates into information, and connecting these dots would give you particular knowledge and insights on what would work and what would not work. Because we have tried a tremendous amount of agents, repurposed different agents, even now for COVID-19, and many of them have really transformed into clinical benefit. And then suddenly you know that some of these agents will actually work out for you. Otherwise, it could be really conspiracy. You can also make a conspiracy theory based on all these things as well. I just want to wrap up by saying that if you have a patient and someone who comes in the hospital who is not sick, who is not on oxygen, what we should do is that we should not give him dexamethasone. Don't give him dexamethasone, because that can make it worse. If that person progresses and now he needs oxygen at this time, you can give dexamethasone and remdesivir. Both of them, most people will actually give them. And that's the standard of treatment. If they go more progressively worse and they are now intubated and they are on a ventilator support, dexamethasone is the main thing. You could use remdesivir. A lot of people will give him remdesivir, but the effect of remdesivir in the people who are mechanically ventilated is significantly lower than the earlier disease group. Hospitalized patients on mechanical ventilation, dexamethasone is the way to go. In some of the subgroup of people in age where you can get the other agents like interleukin-6 antibody or baricitinib, you use that. So dexamethasone and remdesivir are the mainstay of the treatment once you have COVID. If you have early COVID, monoclonal antibodies is the way to go. So in generally, let me just summarize, remdesivir treatment is associated with good benefits. So you can use them early in the disease. Convalescent plasma, high titer convalescent plasma is the only one that works. You can give it to even patients early in the hospitalization because all you need is just a donor who recovered from COVID. You can easily give it to them. Monoclonal antibodies, if you can afford them and you can available, is very good in preventing complications, and you should generally recommend that. Corticosteroids are the mainstay of treatment. Everybody hospitalized sick should get corticosteroids. That reduces mortality. The other agents such as baricitinib and tocilizumab can be added if you have access to those monoclonal antibodies and you have inflammation markers available. Now I'll stop here and I'll take questions.
Thank you very much, sir, for the excellent talk and the details presented. Sir, regarding the use of monoclonal antibody, so what about the duration or how long it may function within a person?
Great, very good question. So monoclonal antibodies, they are humanized monoclonal antibody, and it's given as soon as possible. Most people recommend within 72 hours, and they will stay in the circulation for at least most humanized monoclonal antibody about 3 to 4 weeks. That's the half-life.
Yes.
The only point, so that you don't have to give it again, just one time. That's enough. So if you give it early enough, you should get recovery from that. The only caveat is that if you happen to take monoclonal antibody, then your immune system is slightly messed up. And if you give a vaccination right away, then your efficacy of the vaccine may not be good because you have neutralizing antibodies already in the bloodstream. So the recommendation is to wait for a while. And you can just wait for 90 days is what recommended, but as long as you can wait within 2 to 3 months before you take the vaccine is what's recommended. Sometimes you may take one shot. In between the second shot, we'll still wait the second shot to wait for 90 days to get the booster shot.
Sir, also, especially in India, we have a range of traditional system of medicine. And at the same time, at this time of COVID-19 also, there are many recommendations, especially based on ginger, turmeric, based on active principle like curcumin and so on. So can we have any sort of scientific evidence to support its benefit?
Right. So I think we are not any far from this, right? When we were in last March, we were using every single thing that's available. And the question is that, okay, so you can make any agent as a sense for it. Like, for example, you take a protease inhibitor, it blocks a protease, which may have an activity. If you take a hydroxychloroquine, it changes the pH, it may have an effect. Ivermectin, it may have an effect in changing, the proteins, and so that may have an effect in, controlling the disease. So, and you can show that in some kind of tissue culture system also. But when you use them in patients, we have to show the benefit. And I show you all, this is one of the reasons I show you all the data. Even with those things that we recommend, the data is not very good, right? The remdesivir, none of these things are actually, you look at different studies, you get different patient population. That's why only some subset of people actually recommend. So you need those kind of large studies to demonstrate efficacy of this medication. Most people don't do it because many of the medication we're talking about is already available. They're already approved for other conditions. So you can actually go and get it, and any doctor can prescribe it. So that creates some confusion in the field, and we use a lot of these medications without clinical data to support. The challenge with COVID-2 is that you have this viral replication and then the host immune response. So the timing is important. I think so. Some people may benefit from some medication. Some people, like corticosteroids, will not benefit early in the disease. Remdesivir is not going to benefit later in the disease. And we didn't know about this 1 year ago. So only after much study. So it's very difficult to give blanket approval based on laboratory data because it may not be beneficial.
Yeah, sir, also based on the data, can be any basis like any population is more susceptible to COVID-19, or do we have any data like that?
Yeah, that's a really good question because whether, especially with mortality, and if India had the first wave, the mortality was quite low. And there was some concern that, there is some enthusiasm that, hey, we are more, maybe much better tolerant, our mortality rate is not correct. However, in the second wave, things, our mortality went up. and I think that also gave us a bad sense of like confidence. Okay, it's not a big deal, and great from a public health point of view was probably not a very good outcome. Of all the things that I mentioned, the key element is that the older we are, the worse the COVID-19 is going to be. That's a clear definition, and that's partly because as we get older, we are going to get more diseases. That's going to affect a lot of these things. We really don't know the exact mechanisms of why diabetic people will get bad COVID. It will take years to find that out. But right now, I think that's the key, the best advice you can give. For older people, that's we need to protect them because they are more susceptible, and it could be because they have other comorbid diseases.
Thank you, sir. Now I suggest the students to have more interaction, please.
I have one question. Why certain vaccination require only one dose and certain vaccination require 2 doses?
Right. So I look, everything about COVID is right at the time, wrong later, right? So people have to make these decisions based on what information they had in the beginning. It's a new disease. We had no correlative protection, immunological correlative protection, and people had to make and you had to think about it. We had to do these studies. So usually you do a phase 1, phase 2, and phase 3 study, right? The phase 3 study is the one going to lead to approval of the drug. With the COVID vaccines, there were no phase 2 before phase 3. Phase 2 was done after phase 3 because you just didn't. There was so much a need for making a vaccine. So a lot of these things were rushed. And the rationale for that is that mRNA vaccines, people thought that you probably need a booster shot to get the maximum effect. That's based on some non-human primate data, not based on patients' data. That was the original support. With the adenovirus vaccine, the challenge is that you have adenovirus along with the spike protein. If you have immunity against that adenovirus, then vaccine would not work. So if you give the same vaccine again, you can get antibody response against adenovirus and may not have the booster shot may not work very well. So that was one of the concerns that people had. So we just need to give one shot, and that one shot adenovirus vector should be fine. And over time, we found out that we did not know about variants. Variants really complicated it. If we didn't have variants, that would be fine. These shots, nobody will have to worry about this again. Now the variants came, and the variant effectiveness of these vaccines against variants were diminished. So that's why we have a concern about adding more shots, and that created confusion in the field. So originally, that was the data that people thought. If you look at it, single shot of mRNA vaccine probably was really good. It was a study from Israel showed that 85% efficacy in that shot from Pfizer mRNA vaccine. So you could say, hey, if there was no variants, one shot of mRNA of all vaccines would have been fine. But we didn't know that.
Okay. Thank you. We have one more question. Unlike smallpox virus, usually smallpox virus, once you have it, you won't get it again, right? So why COVID come again? You get sick again.
Right. Why do you get sick again with COVID-19?
Yeah.
Right. So there are different viruses are different because it depends on what type of immunity you develop against the virus and how the virus mutates. Right. So if you have an immunity against the core part of the virus and that does not change over time, that's what protects you from smallpox. Then you are protected until you lose that immunity somewhat when you become older. But in SARS coronavirus, most of the protection is against the surface of the virus. And that surface, we know that it changes over time whenever there is variant. The surface changes because the virus wants to adapt its binding capacity to the receptor. So you can see that Delta binds better than the Alpha. So that's why it spreads much faster. So then that changes, and that's your also the area that you're protecting against. That change will then make you susceptible. That's why people who got the vaccine against one particular strain is no longer protected against Delta. So those are the two fractions. The type of immunity that generate and the region of the virus that mutates dictates the long-term immune response. Influenza is the same example. You don't develop strong response to influenza because your protective immunity is against the hemagglutinin that is on the surface. and that keeps changing over every year. So that's why we have to get immunized every year. And you can get influenza again. It's the nature of the viral mutation and what the correlated protection is.
No more questions. I express sincere thanks to sir on behalf of Mahatma Gandhi University and also on behalf of our SRIP KSCST. We express our sincere thanks to you for supporting us by your kind acceptance on our invitation.
Sure.
So thank you very much, sir. And we will be requesting your help in future also.
Sure.
Thank you.
Please, anybody can email me, please, if you have any other questions,
Yeah.
please.